So what you've just heard over the last several hours is exactly the same thing that we try to teach to our medical colleagues, physicians, nurses, and others. The only difference is we use more Greek, Latin, and French terms, we use more abbreviations, and we take twice as long to tell them the same thing. You guys are actually in the fast track here, but I think the major takeaway message here, there are two of them. One is, in fact, treating MS is actually quite complicated. It's not easy, and it's getting more complicated every day. But in that complexity is opportunity. We can do a better job now than we've ever been able to do in the past, but it requires an active effort. So if you're like me, when I go to see the physician, I want them just to make the decisions, tell me what to do, and let me go. But there are patients that I have that they want to know all the information that I have so that they can make their own decision. And then there are people who are in between. That's perfectly normal and perfectly all right. This program is designed for those people who want to have all the information themselves to make that decision. We're providing all of that to you. For those of you that don't want all that detail, just take away the big picture items. That's the only important thing. So what I'm going to do here is I'm not going to go into as much detail. I'm going to be more on the concept and sort of applying it to patients. And you must understand that what I'm going to be talking about is my worldview of MS. Dr. Corboy, Dr. Bennett, Dr. Miravalle, we're all similar, but we're not exactly the same. And that's just a reflection that the data set is not complete yet. And so how we emphasize different aspects of that will vary a bit. We're much more similar to each other, though, than the broad community of neurologists are. So you'll see ranges in the community, everything from somebody who only uses one agent because that's what they're most comfortable with, to centers like ours that use all the agents but tend to focus more on the newer agents. I don't know who's right either. John is absolutely right that in order to ultimately prove this, we've got to do the appropriate studies, and those comparative effectiveness studies are probably the single most important things for us to do. So this is my disclosure slide. I do work with a lot of companies, and they hire me to advise them or to interpret data with them and to maybe help with study design. And we also have a lot of grants, including the NIH here, which we have a $1.7 million grant over 7 years to help us with some of the phase 2 research. The goals of therapy have really changed over the last few years. It used to be that our primary goal was to slow the progression of disability. And that's because that's all we could expect out of Copaxone and interferons, is that if you treated 100 or 1,000 patients with those drugs, on average, they would do better than patients on placebo. But as John mentioned, by and large, we didn't see a large percentage of people going into what we call a disease activity-free state. However, more recently, we do see drugs having a higher probability of inducing this disease activity-free state. And this is a term that we use in the field recently to try to identify outcomes where patients appear to be very stable. They're not having relapses, they're not getting worse in terms of disability, and their MRI is not showing any new disease activity. This is a much more rigorous way to define an outcome, and it's something we actually can do in the clinic as a therapeutic goal. But I would argue that with some of the therapies, for example, I'll show you a little bit of data from Tisabri, that a better goal is not just to try to shut the disease process down, but actually try to get improvement in function, to improve symptoms over time. And in fact, we are getting better at doing that. We do not yet have the goal, our goal, which is to cure MS, so we're at this level here, so we still have a lot of research to do. So I'm going to go through a series of topics very quickly here. You've already heard most of the data and the arguments for what I'm going to tell you. I'm just summarizing what they said. So the first one is on the importance of preserving gray matter. Gray matter is where the neurons are. That's the surface of the brain and some deep nuclei. That's where all the processing, that's where the computer is. White matter are simply the cables that connect the computers. So we tend to think of MS as a disease of white matter. It's not. It's a disease of the entire central nervous system, and the neurons, which are the computers, are being damaged and targeted just as much as the white matter is. And the most important study for this was just published this late last year from Claudia Lucanetti. This is human pathology, and you don't have to take my word for it, but basically this slide right here shows neurons that are dying and being removed by phagocytes, which are the garbage men of the nervous system that remove debris. And the point of this is that this biopsy, or this pathology, comes from patients who are getting a brain biopsy as part of the diagnostic phase. So it was the very first presentation with the disease, the very beginning of the disease clinically, and they had an issue where there was confusion as whether it was MS or whether it was a tumor, So they got a small biopsy done. And the point of that is that gives us the earliest window on what's going on in the brain. At the very earliest time point, nerve cells are dying and being attacked in MS. And so the perception that many of my colleagues have that that's a late consequence and occurs when you have progressive disease is wrong. We have lots of data now. This is an early occurrence, and it's actually the loss of neurons that has the biggest impact on your disability. So this is the T1 black hole and gray matter volumes that Dr. Corboy was talking about as predictors of bad outcomes. Losing nerve cells is not good. So the second point is the concepts of progressive disease. What is different between relapse-remitting MS and progressive, either secondary progressive or primary progressive MS? Generally, most of the world out there believes that the difference is that the nature of the immune attack changes in the progressive form of the disease and that neurons are now targeted. It's now a neurodegenerative disease. But as I just told you, that's not true. Nerve cells are targeted right at the beginning. So what's the alternative explanation? And to get to that, we have to think about a concept called neuronal reserve. So you have billions of neurons in your brain, and those neurons are connected by many different interconnections. And if you take that interconnectedness, which is a three-dimensional construct, and add one more dimension to it, which is that it's constantly changing based on your education and physical activity, it's a four-dimensional concept where your brain performs the functions that it needs to do by using that entire neuronal network. And if one part of the neuronal network is not working well, it can shift functions to other parts of that network. And so in relapse-remitting disease, when patients feel that they're clinically stable and physicians think they're stable, we know by MRI that they're not, that their disease is active, their brain is being injured. But the reason they appear to be clinically stable is because they have enough neuronal reserve to mask that underlying disease activity. The problem is we have other reasons why we have neuronal reserve, and that is to allow us to age normally, because the fact is, whether we have MS or not, we lose nerve cells as we go through life. The problem is MS is using up the nerve cells at an accelerated rate. Okay? And so because we know that to maintain that stability between relapses is due to neuronal reserve, then by corollary, the onset of progressive disease represents the point where you've now used up that neuronal reserve, at least in some system, and now you can't mask that underlying disease activity. And now you're going to notice slow progression of symptoms even without relapses. More importantly, there are two causes for that ongoing loss of function in progressive phase. One is the inflammatory attack on the nervous system, which characterizes MS, but as Dr. Corboy mentioned, that's decreasing as a function of age. The second cause, though, is just normal aging. If you don't have any reserve function, you can't mask just normal aging and deconditioning. And so that again goes back to Dr. Corboy's comments that intervening early is really key if you want to fundamentally change the outcome of this disease. So if I put all that together in a model, this is what you've already heard about. You've got relapses up here, you've got MRI disease activity down here, and both relapses and MRI disease activity are most frequent at the beginning of the disease, and they're falling off as a function of age. And that transition, when you go from relapse-remitting to the secondary progressive phase right here, most likely represents the loss of that neuronal reserve function. And in fact, the neuronal reserve hypothesis really very nicely explains a whole lot of things in the biology of MS. In addition, though, if you look at the ratio of the number of MRI lesions that are newly forming versus relapses, in reality, it's about 10 to 1 to 20 to 1. So only about 5 to 10% of these new MRI lesions are going to hit a critical pathway and show up as symptoms, maybe in the optic nerve, maybe in the spinal cord, maybe in the brainstem, areas that are more eloquent and more susceptible to injury that leads to symptoms. And if you build a statistical model where you have 1,000 MS patients and you give all those MS patients 10 new lesions per year, which is about what we normally see, and you give each one of those new MRI lesions a 5 or a 10% chance of being associated with a relapse, and this is a random relationship, and you just let that model run over 30 years, what you will find is that about 10 to 15% of patients will get out to this point out here without ever having had a relapse, and yet they've accumulated the same brain injury. And that explains the onset of primary progressive MS. So right now, the data would suggest, immunological data and clinical data would suggest that this is all one disease. The reason I point that out is that the FDA believes there are 3 diseases, and they require us to prove the therapy work in all 3 forms. It costs about $1 billion to prove the therapy in relapse-remitting MS. It costs about the same amount to do it now in secondary progressive and in primary progressive. That's why most companies have not tried to do that. It's just not financially possible. The other thing that's important out here is that, as Dr. Corbray mentioned, is that late in life, the disease often burns out. And that explains why if we just go out here and treat these patients with immunological therapies that we're talking about, we really don't see much treatment effect. So again, it emphasizes that if you really want to change what's going on out here, you got to treat back here. And we'll ignore the rest of this stuff. Now, this is the way that we see that neuronal reserve and plasticity. This is a functional MRI, and this is a normal healthy person tapping a rhythm with their dominant hand in the MRI unit. This is an MS patient who at this time has normal function in that right hand, is doing the same thing, but they had had a relapse early in their disease course that affected the right arm. And what you can see is that all they're functioning normally now, they're using more of their cortex. So the red, yellow, and blue dots here are areas that are active and using a lot of oxygen. And you can see they're using more of the cortex to do the same thing. And so this just points out that we actually can see this cortical plasticity, and we're working on ways to actually quantitate that and measure that as another outcome measure in addition to all the other ones that you've already heard about. Now, one of the important things to think about when you're thinking about neuronal reserve is there are two factors, groups of factors that determine how much neuronal reserve you have. The first one is genetics. It's how big your brain is and how many neurons you have. There's not a whole lot of variation in that, and the fact is we're not that dissimilar in that number. But the second one are environmental factors. It's how well you had, or how good your nutrition was in early life when your brain was developing. It's how enriched your environment was, learning, activity, physical activity, and exercise. So cognitive activity and exercise actually create more connections. When you're physically and intellectually active, your nerve cells actually put out new branches, and they connect randomly with other nerve cells in the region. If you continue to be physically or intellectually active, and some of those pathways represent more efficient pathways to do something, you capture them and make them permanent. That actually explains why professional athletes train the way they do. They're trying to capture new wiring in their brain that allows them to perform whatever they want to do in a more efficient way. The same is true for all of us. So the point is, if you take exercise and you add that as a therapy to MS, you improve symptoms of an MS, and you improve it, and not just in terms of symptomatic things, but also in function. We actually see an improvement in cognition. We see an improvement in balance. We see an improvement in strength, and we see an improvement in gait. And so to increase that neuronal reserve in patients, at our center, you're going to hear about the need to do exercise. And that's the reason, is to help you recover function and to mask the injury of the brain by expanding your neuronal reserve. This is an example of it. It's a paper we published recently with Carolyn Schwartz. And this is taking about 4,000 patients with MS and classifying them as being active early in life or active now. And if you do that, there's 4 different groups you can get. But the point is that the people that were always active represent this green line. And the closer you are to the center, the more normal you are. And what you can see here is that if people have been active, they're less likely to have mobility problems, but they're also better in almost every other capacity: spasticity, memory, bladder, cognition, fatigue, vision, and pain. And if the blue line represents people that were not active in early life but are active now, and they're better than the people who were active in early life and not active now. So what this tells us is that activity improves your outcomes, and it does it most if you're active now in the disease. It also is beneficial if you're active as a child, but the most important factor is being physically active now during the active disease. And this is a number of papers published at abstracts and other meetings and as papers looking at Tysabri. And again, this is just the first evidence that we really have that if you use highly effective therapies, patients actually do improve in function. And so we don't think that the Tysabri is going into the brain and inducing repair functions. What we think is happening is that Tysabri is shutting down the process that's damaging the brain so completely that now being active and living a healthy lifestyle shows up as an improvement in function because you're creating more of that neuronal network. You're creating more of that neuronal reserve. And again, it's not just in one domain. It's throughout all domains: memory, cognition, hand function, walking, quality of life, and even employability. Patients on this study were more likely to go back to work on Tysabri than they were on the alternative therapies, in this case, a placebo. So one other just brief comment here is that another thing that's happened recently in the field is that because of the therapeutic trials that we've all done, we've come to realize that the prior view of the immunology of MS is actually wrong. It's based on animals, and in the animals it is correct. It's a very detailed understanding, but in humans it's actually different. And this is the power of clinical trials. This is a table of the therapies that we have or will have shortly, and it just points out they have different levels of relapse rate reductions, they have different effects on relapses, have different levels of effect on preventing disability progression, they have different effects on MRI, different effects on brain atrophy. But the other thing that they do is they have different mechanisms of action. So they're basically tools, probes that we can use to dissect the immunology of MS in patients themselves. In the animals, the way we do this is you isolate the cell or molecule that you're interested in, and you move it from the animal that has disease and the animal that doesn't have disease and see whether you get disease. We can't do that in humans, so the only way we can do that is to use these therapies to go in and change the way the immune system is working, and then ask, what does that do to the disease downstream? And I put in yellow 3 therapies that I think have had the biggest impact on really clarifying really important points in the biology of MS. The first one is Tysabri, and Tysabri is a very selective molecule that works by blocking the ability of immune cells to simply get into the brain across the blood-brain barrier. And it turns out it only attacks one molecule called alpha-4 integrin, and it tells us that in the brain, alpha-4 integrin is actually absolutely essential for lymphocytes to get into the brain. That's not true in mice. Mice have other mechanisms that allow cells to get in. And as a result, if immune cells can't get into the brain, then the disease actually decreases in activity in a rather dramatic way. And this is the most effective therapy we have right at the moment that's FDA approved. And so this very simple process of simply blocking the ability of the immune system getting in the brain has a large therapeutic effect. The next one is down here. This is rituximab rocalizumab that Dr. Corboy mentioned. This is a therapy that only attacks one type of immune cell called a B lymphocyte. And in the animal model, B lymphocytes are not very important. But it turns out that in human disease, B lymphocytes are very important. In fact, if you compare the ocrelizumab to Tysabri, it suggests that it may be more effective than Tysabri. That simply eliminating B lymphocytes from the circulation, not from the body, just from the circulation, has a huge impact on the disease activity. And this is not explained by the current models of immunology of MS. And then the last one I'm going to spend a little more time on is laquinimod. Laquinimod is a molecule that was derived from an old molecule called linamide that was studied in MS and had some benefit but had major side effects. And so a pharmacy company took the linamide and re-engineered the molecule to get rid of the toxicity, and they came up with laquinimod. They didn't know how it worked. It was empiric observations. But this has now gone through human trials and is going to be approved in Canada and Europe this year, or in 2013, but probably will be about 3 more years before it'll get approved in the United States. This drug, we now know, does not work by suppressing the immune system. It does not affect your lymphocytes. We can't actually find any effect on it. But when we use it in patients, it does have benefit. Its impact on relapses is actually quite small. It's the smallest of all of these except for maybe Avonex. And actually in the study, Avonex and laquinimod had almost identical levels of relapse reduction. But it has a much bigger effect on disability prevention and on brain atrophy. These effects are almost as large as we saw with Tysabri, 33% reduction in brain atrophy. So, excuse me, this drug seems to be working downstream from where these other drugs work. And I just wanted to show you that in a little bit more detail. So this is the traditional model of the immunology of MS. And this is in the periphery, lymph node, spleen, maybe skin. This is in the blood vessels, and this is in the brain. And you can see there's a lot of information about T cells and microglia and macrophages and dendritic cells here. And the B cells sort of down here on the side, maybe possibly being involved, but kind of an indirect pathway. This is all wrong. The B cell should be up here, and the T cell should be the minor player, because we've done a lot of studies on T cells, blocking them selectively in various ways, and they have no particular benefit in MS. That doesn't mean that they're not involved, but it means they're not the driver. However, in this model, you can see we're focused on the immune system. The nervous system, which is represented down here, is kind of an afterthought. And this is actually coming to be a much more important part of it. So these structures down here that are in the brain represent the nerve fibers here, which are attached to the neurons, which should be up here. This is the myelin-forming cell called the oligodendrocyte. This is a cell called the astrocyte. The astrocyte makes up 70% of the brain volume. It's the most common cell in the brain, and it's the one that maintains the microenvironment in the brain. Oligodendrocytes are about 20%, and neurons are about 10%. Now, the point of this is that up until recently, we've basically ignored the role of these cells. This cell we've suggested as a target. And what you've already heard from various people is that, yes, it is a target, but the nerve cell, which should be sitting up here, is also a major target. But by and large, we've ignored this cell, the astrocyte. And I'm not going to go through all the data because we just don't have the time right now, but there's a new model based on the laquinimod story that helps us understand a little bit more about why the laquinimod works. So in this model, we have the T cells that are in the peripheral blood that may or may not be actually targeting the brain. They may just be normal, naive T cells. They migrate into the brain, and they interact with the B lymphocytes that reside and live in the brain. The B lymphocytes actually turn these cells on and mature them and target them towards brain antigens based on the current data. They then release these hormone-like substances that Dr. Corboy talked about that are signaling molecules, and one of the cells they signal is the astrocyte. And when the astrocyte senses those molecules, they become activated. They become big, beefy cells. They upregulate a whole lot of different proteins, and they begin to produce fairly toxic factors such as tumor necrosis factor and nitric oxide and oxygen-free radicals. Nitrogen oxide and oxygen-free radicals are toxic molecules in the body. They damage proteins, they damage DNA and RNA. And so you've heard a lot in the lay literature about antioxidants being used. Well, this may be the first really effective antioxidant in MS, and that's laquinimod. But basically in this process, it's the activation of the astrocytes that actually leads to a lot of the damage, because this nitric oxide and TNF kill the oligodendrocytes. They also kill neurons and the axons. And we have pretty good data for that now. And the way, I'm not going to show you all the data, but the way that laquinimod appears to work is that it doesn't work up here. Instead, it works right here. It inhibits these astrocytes from producing this nitric oxide and oxygen-free radicals, thereby decreasing the toxic environment that occurs in the brain. And it's a remarkably safe drug. So basically what I'm telling you is that this is the rational basis for combination therapy. We now have therapies that we can target out here to prevent these cells from crossing the blood-brain barrier. That's Tisabri. We have rituximab that can target this cell and remove it from the system. And now we have laquinimod that can prevent these cells from being activated as a result of this. And so if you think about that, that offers very interesting ways to begin to ask about how to use sequential and combination therapy to get much better effect with less toxicity. Same that's been done in oncology and in HIV. So this review of the recent and about to be available disease-modifying therapies is going to be very brief. Again, this is the same slide that you saw before. And the therapies I'm going to talk about are going to be Gilenya, just briefly because it's been out about a year and a half, BG12, which hopefully will be out in March or April, and teriflunomide, which was recently approved by the FDA. You can see here that teriflunomide, again, as was mentioned by Dr. Corboy, is about the same as the interferons and Copaxone. It's about a 30% reduction in relapse rate. It did decrease disease progression in terms of disability by about 30%. It did decrease MRI disease activity by about 70%, and it did decrease brain atrophy by about 30%. As was mentioned before, this drug does have, by Dr. Miravalli, this drug does have side effects of nausea, mild vomiting, diarrhea, hair loss, and fatigue, but they're relatively mild and on magnitude are probably about the same as we see with the interferons. So in terms of the risk of having an adverse effect, not feeling well on the drug, it's about the same as the interferons. And so probably is very competitive with those. Fingolimod, on the other hand, has about a 50 to 60% reduction in relapse rate. Again, about a 30% reduction in sustained disability, and that may be a technical issue that sort of comes there. Larger effect on MRI, similar effect on brain atrophy. Now this drug, as was mentioned earlier, if you have cardiac disease in particular, or diabetes, as Dr. Bennett mentioned, this is not a good drug because those kinds of concomitant illnesses can substantially increase the safety profile. But if you don't have those, if you don't have any other major systemic diseases, the risk of having a side effect from fingolimod is probably not a lot different than the interferons and teriflunomide in terms of the risk of a serious problem. It'll be a different problem, but the magnitude of the risk is about the same. Again, that's for selected patients. And then BG12. Dr. Corboy gave you some of the key data on that, so I'm not going to reiterate it. Again, it's very similar to Gilenya in terms of its reduction in relapse rate. Had a good effect on disability, good effect on MRI disease activity and brain atrophy. And again, this drug differs that this drug really is affecting the immune system right now based on what we know. This drug does not seem to have a big effect on the immune system, although it has some. And so this may work by a different mechanism, and I'll explain that slightly. Teriflunomide, though, is strictly an immunosuppressive therapy. It doesn't do anything else. So this is the Gilenya or fingolimod. It's not a very good cartoon, I agree with you. Think of these cells here as being in the blood supply, so these are floating around in your blood system. These are your T cells and B cells. They should actually have B cells here. What happens is that the lymphocytes that are in your blood routinely migrate into your spleen and lymph node on a probably twice a week basis, at least once a week. And they go in here and they get what we call educated. So some of them are going to be removed, some are going to be promoted, some are going to affect B cells and do other things in the immune system, but they're in the spleen and lymph nodes here. And then they migrate out after a few days. They migrate out and they move back into the lymphatics, which then dump them back into the blood vessels. The way they get out of the lymph node and spleen is they follow a gradient of a chemical called sphingosine-1 phosphate. And it's just being produced near these exit points, and it diffuses backwards, and so they're following that gradient out. And all fingolimod, or Gilenya, does is it blocks the receptor, essentially blinds the cell so it can't see that gradient, so they can't find their way out of the lymph node or spleen. So they're not killed, they're simply locked up. They're in jail. And they're not in the circulation. And the hypothesis is that if they're not in the circulation, they can't get into the brain, and that may explain the effect of Gilenya on MS. However, Gilenya does cross the blood-brain barrier. It has effects on a number of neural cells, and it may be acting directly in the brain as well as a similar to laquinimod, as almost a neuroprotective agent. And so that's still under investigation and something we'll have to look into. Teriflunomide, on the other hand, is very similar to other chemotherapy drugs that we have, and I know that some people in the audience are cringing when I say this, but there's an old drug called azathioprine, which has been studied in MS. It's a pill. It's used in cancer treatment, used in other autoimmune diseases. And these drugs basically work by inhibiting the synthesis of subunits that are needed for DNA and RNA synthesis. So it's inhibiting the ability of the cell to make the RNA that it needs to make in order to produce the proteins that it needs to do to have for whatever function it's going to have. So it's primarily inhibiting the ability of the immune system to grow and develop. And that has, as I said, a moderate effect on MS, and they have proven it with good studies. The reason you get the nausea, vomiting, and hair effects is because it's inhibiting the ability of other cells to grow and develop as well. And then BG12 is a different kind of therapy. You've already seen this data. This is the key issue, is we think BG12, in part, is activating a gene pathway called the NFR2 pathway, and that's the pathway that produces the antioxidants that help protect the immune system from those oxygen-free radicals and nitric oxide that we think are coming from the astrocytes, as well as other cells that can produce them. It may also inhibit a pro-inflammatory gene pathway that helps lymphocytes and other cells activate to produce the signals that increase the inflammatory environment in the brain. It probably has other effects as well, but there's reasonably good evidence that it has these genetic effects. So this is a unique mechanism of action, and as I said, its side effect profile does not reflect suppression of the immune system. We don't really see a rise in infections. The side effect profile is primarily hot flashes, stomach irritation, because it's a contact sensitizer, so stomach irritation like gastritis can occur with it. As was mentioned, there is some concern that it may cause gastric cancer in animals. That's not been seen in humans so far, but for me, that's one of the more important safety signals that we'll be looking for as we go forward. But the drug actually, from the standpoint of a risk of a serious adverse event, is definitely comparable to the interferons and Copaxone. It's not fundamentally different. And so many people in the field feel that BG12 is likely to be the first real alternative for most patients that are on injectables that want to switch. And the drug is more effective than Copaxone and, by extension, more effective than the interferons on average. And what I mean by that is that I can put a patient on any given therapy. I can't predict what's going to happen to them. All I can say is if I treat 100 patients with drug X, a certain percentage of them are going to do well and a certain percentage are not. The percentage of people who are going to do well on BG12 is higher than it is for people on interferons and GA. Again, it doesn't help me figure out what's happening in the individual case. So what we've talked about is that the BG12, let me just get through this thing here. I showed you this slide before. BG12 may be working a bit here and a bit here. Teriflunomide is working out here by just decreasing the number of cells in circulation, as is Gilenya. It's just decreasing the number of cells that are in circulation out here. So there are important additions to the overall opportunities that we have, and again, I think will be significant for a number of patients. And then finally, this is what Dr. Corboy was talking about, is the complexity of selecting a therapy for an individual patient. The first thing is that we divide patients up into two groups, those that have JC virus antibodies and those that don't. For me, this is an absolute. I do this with everybody because the risks and benefits of these therapies vary substantially based on this dichotomy. And once we have that, then I classify people into 3 categories. As I mentioned before, only about 10% of patients would have what we call benign MS or low risk. The point of that is most patients are going to have some significant disability occur if we don't treat them. Then there's a middle group, which is the largest group that have average, and then there's maybe a 30% that are in that high-risk group. And these are rough numbers, and I can't tell people the difference between people who are maybe at 20% versus 50%. There's no one can do that. All we can do is basically have these rough estimates of what your risk is, and that's as refined as we are today. And if you have no evidence of the viral infection, and you have an average risk of disability, then this is the way that I would rank the therapies. For me, as Dr. Corby was pointing out, it may make most sense to treat early and aggressively, and I think there's very good reasons for that, although we don't have the definitive studies. And as a result, if you're negative for this, I would probably choose Tisabri, and the reason for that is that if you're negative for this virus, then the risk of Tisabri for a serious adverse effect is no greater than interferons, less than Albagio, less than Gilenya. Okay? So in terms of the chance you're going to have a serious health problem, in this situation, Tisabri comes out very good. Rituximab is off-label use and complicated, and I don't want to get a lot into it, but it's a very important therapy. And I would just point out that although the insurance companies and Medicare doesn't approve it for you, they approve it for people with neuromyelitis optica, which is another demyelinating disease we deal with, and that has even less evidence for it to support it than what we have in MS. So I think it's kind of a dual standard here that probably needs to be addressed politically. If, on the other hand, you have a high risk of disability, then alemtuzumab moves up, and that's because of that autoimmunity problem that Dr. Corboy talked about. On the other hand, if you're JCV antibody positive, Tisabri drops to the bottom if you have average risk of disability. Rituximab, BG12, and Gilenya are near the top. And the color codes here are is that I can't tell the difference between the yellow drugs. I know that they're better than the orange drugs, but the orange drugs, I can't tell if any of them are really better than one or another. These drugs are down here because the risk is so much higher. So that's the color coding. If, on the other hand, you have a high risk of disability, then again, the drugs down at the bottom move up. And they were here. Alemtuzumab and Tisabri, in my view, are essentially equivalent. Unless you're chemo exposed, then Tisabri is probably not an option. Rituximab, though, would be the best option because it has the best safety profile. And then you have the Gilenya and the rest of the therapies. So the bottom line is that this is the way that I approach it. It's not the way the world approaches it, and that's going to continue to evolve over time. But what I think you are seeing is that most of the major MS centers are not very different. We seem to be arriving at almost the same point. Slightly different pathways, slightly different rates. So the data is compelling to us. And what you've heard this morning is the complexity of that data and the details behind it, but those details are important because they are helping us make better decisions. And in the future, the bottom line is we need comparative effectiveness studies. We need to have patients that are actually put on these different agents and then followed prospectively, and we need to be asking the patient how well they're doing, and we need to use that patient-reported outcome as the primary strategy for determining the best therapies long-term. And that combined with the biomarkers and other things, I think will improve our ability on an individual basis to help you select the best therapy that gives you the best chance to avoid any further loss of function and live normal lives. Thank you very much.